So welcome everybody to the BCDHA Webinar, Antibiotic Stewardship. It's time we heard the truth. What does the dental hygienist need to know? So far, I think we got about 34 attendees online right now. And I think more people will be popping in as we go, so that's fine. So we're just going to get started.
Great.
Go ahead. I just have a few things to cover there, Kate. So I'll just do a couple slides here. Just wanted to let everybody know who I am. I'm the moderator for tonight's webinar. My name is Wendy Jobs. Excuse me. I'm the BCDHA Manager of Dental Hygiene Practice. And with me tonight is the presenter, Kate O'Connor from the British Columbia Centre for Disease Control. At the end of the webinar, we do have a survey link that we would really like you to follow. I will put... Sorry, I'm just monitoring here, people coming on. I'm just going to make sure I'm muting everybody as they come on, because that way we're not hearing dogs barking and stuff in the background. I've been with BCDHA for over 4 years now, and I absolutely love my job. I was an educator prior to that for 20 years. I currently work in residential care, and I have 2 dogs and 3 grown children, one of which is who's still at home going to university. So thanks everyone for attending tonight. The webinar is usually, like most in the past, is designed into 2 parts. We'll do about a 40-45 minute presentation with Kate, and then 10 or 15 minutes for Q&A. Kate has told me that she doesn't mind kind of being interrupted, so if there's some urgent questions along the way, we'll certainly see if we can stop and have her answer those. Just so you know, for those of you that are not familiar with GoToMeeting, this is the mute button up here, so please keep yourself muted. That way we're not hearing things in the background, paper shuffling and people doing dishes and stuff like that. I know that people walk around lots with their mobile devices and attend to other things that are going on in the house. If you're having any audio difficulties, you can certainly call this number here on the screen, and the access code is this number here. So please take note of that in the event that your computer or tablet or whatever you're watching with you're having difficulties with that. And my phone number, my cell right here, I obviously will probably not answer my phone, but if you text me, if you're having any difficulties, I can certainly help you with the text function. So this is Kate. She's a registered nurse educator with the BC CDC's Community Antimicrobial Stewardship team. That's a mouthful. Having previously spent 10 years in public health in terms of nursing, Kate is passionate about upstream preventative health care. She lives in Squamish and enjoys spending time in the outdoors with her husband and her 2 young boys. So without further ado, I'll pass the reins over to Kate. So just give me 1 sec here. I've just got to give Kate the presentation button. There we go. It'll just take a second here for Kate's screen to pop up. Okay. There we go. Great. Thanks, Kate. I can see everything looks great.
Fantastic. So thank you so much, everyone, for having me here today. I'm very excited to talk with you. As part of my role is helping to spread the message of antimicrobial stewardship. And we're very excited to talk to dental hygienists because we know that you are really the face of dentistry, and you're talking to patients and spending lots of time educating patients. So we're very happy to have your attention today. And if anyone does have questions, you can put that in the chat box and I'll answer them as I am able. And I will have time at the end for questions, and I really welcome questions. So I'd love to get a dialogue going, even though we're not directly face-to-face. It's nice when people do feel comfortable to ask questions because we get more of that classroom feel. So I am going to jump right in and kind of just progress my slides, but it's being a bit slow. Hold on a second. There we go. So the objectives today, the first one is that I really just want you to understand the term antibiotic resistance, because it is a mouthful and it can be something that is difficult for people to understand. We will make that easy today, but just I know a lot of people hear that word and maybe start to think, oh, this is too complicated. So we will make it easy. I also want to just discuss the role of dentistry in antibiotic stewardship and how this applies to your practice. And we will unpack a little bit about allergies and understand a bit more about how people's allergy labels can play a role in the antibiotic stewardship. and how you can help patients become more educated about allergies in general. And then we will look at the best practice guidelines for antibiotic use in dentistry. And also I'll point you to professional resources that you can use in your setting and also that you can provide to patients. Okay, so what you see here is a World War II poster. And it was from the late 40s, trying to educate the public about, you know, what a miracle drug penicillin is. So in World War II, penicillin started widely being used to treat war amputations and wounds. And people really started to understand what benefit antibiotics were. Penicillin was actually discovered in 1928 by Alexander Fleming, but it only started being used widely around the World War II time because they realized soldiers could quickly come back to the battlefront instead of being in hospital or sometimes dying from infections. So antibiotics are undoubtedly one of the most significant discoveries of modern medicine. And in the years since they've been discovered, they really have saved millions of lives. So they treat bacterial infections that would otherwise be fatal. And it's important to note that antibiotics are only effective against bacterial infections. Antibiotics do not work for viral infections, which is probably review to you all, but I know that that is often confusing to patients. So it's just important to remember that point. And also that without antibiotics, our modern medical system would not function. So chemotherapy, burn therapy, childbirth, cesarean sections, pretty much any surgery wouldn't be available to us without antibiotics. So they are incredibly important to our entire underpinning of our medical system. And then even though, so we just talked about the antibiotics started being widely used in the late 40s. You can see here the first journal article that started noticing bacteria becoming resistant to antibiotics was published in 1947. So that was only a couple years after antibiotics started being used. So antibiotic resistance can be confusing to people. So I like this quote because it really just helps convey what antibiotic resistance is in plain language. So when antibiotics are used too much or incorrectly, the bacteria causing you to be sick may no longer respond to the medicine and you may continue to be sick. So what confuses people a lot is that they think that antibiotic resistance is something to do with a person's immune system, but that isn't true. It's the bacteria that have developed a way to survive even in the presence of an antibiotic that used to inhibit its growth. So even healthy people or young people can have bacteria in their body that are resistant to antibiotics. So it's nothing to do with your own health, even though people who have compromised health conditions might be more likely to have severe problems because of antibiotic resistant infections, but it's nothing to do with that person's immune system. It's just the bacteria that are in their body. So within a short time of antibiotics being available, we discovered that bacteria can rapidly adapt and change, and that makes them resistant to the antibiotics. And then what's happened is even as new classes of antibiotics were discovered, the bacteria also became resistant to these drugs. And so this is just how bacteria survive. They've been around much longer than humans have. And as there are stresses put in their environment, they mutate and find ways to overcome these stresses and survive. So the stress we're putting in their environment is antibiotics, and the bacteria are developing ways to live even in the presence of the antibiotic. So now we have people who are dying from infections caused by antibiotic-resistant bacteria. And antibiotic resistance poses a huge threat to modern medicine because without antibiotics, most of our modern medical system cannot function. So we really want to preserve antibiotics so that we can have them now and for future generations. So what I'm going to do now is show you a video for those of you who are more visual learners. I'm going to show a video that shows how bacteria can develop resistance to antibiotics, and it will help you understand. The video will be muted because the sound won't easily come through on your screen, but I will narrate through as the video goes along. So it'll just take a second to load, so bear with me. Okay, so I'm just going to rewind this for a second. Okay. So what we have here is a YouTube video that you can Google and play on your own again if you'd like. If you just Google Harvard Medical School YouTube and bacteria evolution, this would come up. So what we have here is a petri dish that they've built in a very large form. So it's 2 feet by 4 feet. And then you can see on this petri dish, they've separated it into 9 separate bands. So each band is normal petri dish thick agar with different amounts of antibiotic. So on the outside, there's no antibiotic where it has a 0. And then just in from that is a little bit more than the E. coli can survive. Inside of that is 10 times as much antibiotic, then 100 times, and then finally in the middle, 1,000 times as much antibiotic. So they poured some thin agar so the bacteria can move. And the background is black because there's ink, and the bacteria appear as white. I'm just going to pause it for a second so I can catch up. So what you can see here is that the E. coli bacteria that they put on the agar first spread where there's no antibiotics, so there's no limits on their growth. The white bacteria are spreading up until the point they can no longer survive. So they met the point on the dish where there was antibiotic and they could no longer survive. And then you'll see a mutant appears on the right, and it's resistant to the antibiotic. So it spreads until it starts to compete with other mutants. And when these mutants reach the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. Then you see different mutations repeat this at 100 times as much. And so you can see the bacteria competing with each other, pausing at each different band when they have to develop new mutations. And finally, after about 11 days, they make it into 1,000 times as much antibiotics as the wild type can survive. So you can see by the process of accumulating these successive mutations, the bacteria develop resistance to extremely high concentrations of antibiotics in a short period of time. So I think that just helps show you how the bacteria can evolve and survive and develop mutations. So this is something that we can't put a stop to. We can't stop bacteria from developing mutations. What we can do is use antibiotics wisely so we don't give them the opportunity to become smarter. Okay, so actually let me just go back for a second. If you can all just think in your head for a moment, just take a moment and think, how many of you thought that antimicrobial resistance was a health issue before today? So how many of you, this was something you thought about, you worried about, was something you were worried about that your parents or your kids might have to deal with? So if it isn't something you worried about, you're not alone. When there was a study last year where some researchers asked 1,500 Canadians, which of the following of these health conditions are you concerned about for your overall health and well-being? And you can see the antimicrobial resistance just beat out psoriasis and was below things like strep throat and the cold and flu. So it's not something that people think about a lot, which is why your job as a trusted health professional, it's so important for you to know about this topic so you can educate people so that they are aware. So one of the challenges of the problem of antibiotic resistance is that people often see it as something that affects other people or a problem for future generations. So similar to another large-scale public health issue like climate change, our challenge is to help people understand that antibiotic resistance is a problem now, and it will continue to get worse if we don't put forth really concerted effort to change. So some people think that antibiotic resistance is a hospital issue or a clinical issue that, you know, it's not something that anyone in the community really thinks about. It's something that the hospitals should deal with. But actually, 80% of all the antibiotics used in human health are dispensed in the community, not in acute care. And the good news is there's a lot of room for improvement without denying antibiotics to those who need them. So with antibiotic stewardship, we still want people to take antibiotics when they need them. What we want to do is start to really make change in unnecessary antibiotic use. So of the 23 million prescriptions that were dispensed in Canadian pharmacies in 2016, 30 to 50% of these were unnecessary. So that's really where we need to make change. And a recent study looked at the appropriateness of antibiotic prophylaxis before dental procedures, and they looked at a 4-year span from 2011 to 2015 in the United States, and they found that 80% of the prescriptions were likely unnecessary. So that gives us a lot of room for improvement without denying antibiotics when they're needed. So another challenge we have with helping people to understand that antibiotic resistance, that it's a problem, is that some people think it's just an issue in the developing world or the global south. But actually, there's about 23,000 Americans who die each year to antibiotic-resistant infections. And in Canada, that number is around 2,300. And we have about 700,000 people a year who die from antibiotic-resistant infections. So this is a problem in every country in the world. And so if you remember, I just said the number right now, there's about 700,000 people in the world who are dying of antibiotic-resistant infections. The UN estimated that by 2050, there will be 10 million people a year dying by antimicrobial resistance. So this is more than the number of cancer and diabetes deaths combined. So if we don't do something to change the path we're on, we will see lots more deaths and lots more complications from antibiotic resistance. So that's why what we do today is so important. And one of the things you might hear from people, or maybe you might think this in the back of your head, it's sort of a normal next step to think about, would be, well, if one antibiotic doesn't work, aren't there just others I can use? There's always got to be something else. But sometimes right now there aren't others to use. So you can see on this timeline, it shows different antibiotics, and the yellow color is when the antibiotic was first introduced, and then the red color is when resistance started to occur. So you can see a couple things on this timeline. One is that resistance seems to be occurring more quickly than it used to. And the other is that in recent years, there aren't as many antibiotics. We don't seem to have as more coming as much as we used to. You can see on this next slide that the discovery of new antibiotics is really not keeping pace with what we need. So in the past 30 years, we haven't had any new classes of antibiotics. And one of the reasons for that is that there's not a lot of money in this for pharmaceutical companies. So if we're seeing resistance soon after an antibiotic starts being used, then the pharmaceutical company isn't making their money. So it's different than like a heart medication that can just be used by people for years and years and years. With antibiotics, the pharmaceutical companies could spend millions of dollars developing, researching, and marketing a new antibiotic, only to have it soon become, the bacteria become resistant and the antibiotic not being used anymore. So even if today, if the government of Canada said, this is a problem and we really want to give incentives to the pharmaceutical companies to develop a new antibiotic, the amount of time it would take to get it on the pharmacy shelves wouldn't help us with this problem. So we really have to be the drivers of change and limit the unnecessary antibiotic use, because every time we use antibiotics unnecessarily, we're just allowing the bacteria to become stronger and to adapt. So by not giving them that chance to adapt, we're saving antibiotics for when we need them. Okay, so I'm just going to take a quick break and see if there's any questions at this point about understanding antibiotic resistance, or kind of what it means on a global scale, or what it means for us as users of antibiotics.
Hi, Kate. It's Wendy. I don't have any questions coming through the chat function, but one of the questions that popped into my mind when you were speaking and when you were talking about that antibiotics seem to be becoming, or the bacteria becoming more resistant in a shorter time frame. Do we have a sense as to why that's happening?
I think one reason is probably because there are more people on Earth using antibiotics.
Ah, okay.
Another reason is that so bacteria can trade. It's a very cool part of bacteria, and very scary, is that they can trade parts of their genome between organisms. So once one bacteria has developed a way to resist an antibiotic, it can share that knowledge with other bacteria. So once you develop one way to survive, you can kind of adapt and more quickly develop another way. So the types of antibiotics, or the types of treatments that will likely be very helpful in the future, might be quite different. Like there's some research looking at making viruses, viral phages, developing a virus to kill bacteria. So that might help us, because it's very different from what we currently have, and
right.
Bacteria just almost like they keep putting on armor and becoming stronger and stronger. If that makes sense.
It's very scary, isn't it? It's quite terrifying, actually. I have a question here from someone. It says, what percentage of prescriptions in dentistry were unnecessary? I think you covered that in an earlier slide.
Yes, so the study from the US from 2011 to 2015 showed that 80% of the prescriptions of prophylaxis before dental procedures were unnecessary. So that's a huge number.
Yeah. Tracy makes a comment, the animal agriculture industry is the largest user / abuser of antibiotics, causing resistance to a large degree.
So that is true. 80% of the antibiotics used on Earth are for agriculture, not for humans. The problem is that the Ministry of Health controls the antibiotic use in humans, and the Ministry of Agriculture is in charge of the antibiotic use in animals. So say my group at the provincial level doesn't have any say about antibiotic use in farm animals. We do have a vet on our team who's looking at antibiotic use in companion animals and change that way. And there are some larger scale groups looking at making a kind of one world, one health plan. Right. But that is outside of our group's purview.
Right. MJ makes a comment, when you think it's really necessary to take antibiotics, but some doctors give obviously antibiotics for a simple cold or a flu. Yeah,
so the research does show that the way to make change is by educating prescribers and the general public. When you only educate doctors or dentists or professionals in the health sectors, there's not a lot of change.
Right.
And when you only educate the people taking them, there's not a lot of change. But when you do both groups together, that's where you see, that's where the intervention works.
The impact.
So by me educating the health professionals and by you educating your clients, that's the way we're really going to change the path we're on.
Right.
Okay, should I keep moving forward?
Yep, go ahead. There's no more questions, so we'll wait.
Okay.
So we'll just carry on.
Sure, thank you. Okay, so I wanted to show you how kind of make this personal to your practice. So this graph here is slightly confusing, so I'm going to take a minute to explain it. But what we have here is can you see my cursor?
Yeah, we can see it. We can see it moving.
Okay. So what we have here on the left is the prescription rate of physicians, and you can see it's per 1,000 people per year. And you can see the scale is from 0 to 800. And on the bottom we have year, that's easy. On the other side here, we have the prescription rate of all other professionals, and you can see the scale is quite different. So doctors are, the scale of their graph is a 10-fold increase to all other professionals, which it should be because doctors are seeing the most number of people and general practitioners are prescribing a lot of antibiotics. But the important thing to see here is that the blue line here for physicians has been going down over time, while the pink line here for dentists has increased 30% since 1996, and it's still going up. So we are seeing an increase in the dental prescribing and a decrease in the doctor's prescribing. All the other professions we're seeing slight increases in, but they're also professions that are very new and have had their scope increasing. So we do kind of expect that we'd see increases in their amount of prescribing. But the important thing here, and also just to note, we get this information from BC PharmaNet, and they only capture outpatient prescriptions. So in 2016, dentists wrote about 319,000 prescriptions for antibiotics, and this represented 12% of all outpatient prescriptions. So that's in 2016, there were 12% of all outpatient prescriptions were from dentists. In 1996, it was only 6%. So that's gone up quite a bit. So in the time that physicians have gone down 33%, dental prescribing has increased by 30%. So that's why we want to, we did a dental campaign this year on SkyTrains and buses and tried to really educate the public that not all dental procedures require antibiotics, because we know that sometimes doctors get pressure from patients. We assume that dentists are probably getting pressure from patients. And so we just wanted to help kind of complete the circle and do some messaging to clients as well as to dentists. Okay, so another interesting graph to show you about your profession is this shows the average prescription rates for the top 5 antibiotics prescribed by dentists. So you'll see that most dental prescriptions are for amoxicillin. And the multiple formulations of amoxicillin make it easier to use, especially for children. But because its spectrum is so excessively broad for most orofacial indications, it's not the #1 choice that's recommended. So Pen-V, which is the teal line, should be the drug of first choice for most indications. But you can see that amoxicillin has been rising quite a bit and Pen-V has been decreasing. So we do want to make a change there and have Pen-V be the drug of first choice and amoxicillin be a second choice. Another interesting thing you can see is the pink line, the clindamycin, that's risen 410% from 1996 to 2016. So we will talk more about clindamycin, but the amount it's been increasing is going up quite a bit, and that is something we definitely want to change. And so another thing that we look at is the days of therapy. So the number of days that a patient is receiving antibiotics. So when we talked about bacteria get stronger, the more chance you give them to be to encounter an antibiotic, the stronger they can get. So 10 days is quite a long average days of therapy for a dental prescription. So what we want to aim for is shorter courses of therapy because they're sufficient for most of the common infections. So we mentioned how clindamycin has gone up 400% since 1996. And dentists in BC have prescribed more than 40,000 courses of clindamycin each year since 2008. And I don't know how many of you have heard of C. diff, Clostridium difficile. This is an infection that you're more likely to get after taking clindamycin. And it is an inflammation of the colon and severe diarrhea that can be deadly. So it is a horrible infection. And clindamycin exposure is a strong risk factor for getting this infection. And I've put a link on my slide here to the Peggy Lillis Foundation website. And there's also a great YouTube video that you can watch that I think is really good to just put a personal face on understanding the risks of clindamycin. So Peggy Lillis was a 56-year-old kindergarten teacher, and she had a root canal, and the dentist prescribed clindamycin to treat an abscess. And then what happened was the next day she felt fine, but then the following day she felt sick and thought she caught a bug from one of her students. So she stayed home from work the following day, which was really unusual for her. She was very healthy. And the next day was Saturday, so she called her GP on the phone and got a prescription strength antidiarrheal, which is incredibly contraindicated with a C. diff infection because it's just keeping all the bacteria concentrated instead of flushing it out of the body with the diarrhea. And 3 days later, she finally went to the hospital. And then the next morning, she died in the ICU from a C. diff infection. So if you do go to her website, you can see lots of patient stories where they've had similar things happen. And that's why we really want to avoid the risk of clindamycin, except in the case where there's no other good options. So one of the reasons why clindamycin is prescribed is because the client says that they have an allergy to penicillin. And so then the dentist will prescribe clindamycin because they don't want to risk an allergic reaction. And you've probably seen many, many patients in your practice with penicillin allergy labels in their chart. So 10% of Canadians do report a penicillin allergy, but there are actually fewer than 1% of them that are truly allergic. So there are a lot of misconceptions out there about penicillin allergy, and I just wanted to take some time to kind of unpack those and educate you a little bit more about allergies so that you can educate patients. It wouldn't be up to you to delabel someone's allergy, but you could recommend that they go talk to their doctor and have further assessments. So the best time to talk to someone about a penicillin allergy is when they're not receiving an antibiotic right then and there, because it might take time to talk through things with their doctor and make decisions and get some testing. So it would be really important if you see a penicillin allergy on a chart and you're doing a regular cleaning, it's a great time to talk about that allergy and encourage them to have a conversation with their doctor. Some people get very used to telling all their healthcare providers they have a penicillin allergy, and they might not even remember why they say they have it. It might be that they had a rash when they were 5 years old and their mother told them to always say they had a penicillin allergy, and now this client is 50 years old and doesn't really know if he has an allergy or not, but has just become quite attached to the label. So some things to just be able to educate the public about. One is that a penicillin allergy is not genetic. So even if someone's mother had a penicillin allergy, a true penicillin allergy, or their sister or brother, it does not mean that they need to avoid it just because their family member has the allergy. And another interesting thing about penicillin allergies is even if someone has a true penicillin allergy, they lose the sensitivity half the time after 5 years, and 80% of the time people lose their penicillin allergy after 10 years. So the longer the time since their last reaction, the less likely they are to still have the allergy. And another important thing to note is that children who have a rash after taking amoxicillin, that can often be due to them having a viral infection that sort of reacted with the antibiotic, with the penicillin, and caused the rash. So with children too, it's really important to for the parents to look a little bit deeper, because when people do have allergy labels, they're more likely to be given a second-line antibiotic. They're more likely to have, for the antibiotic not to work as well, and to have more side effects from the antibiotic. And also they have more of a likelihood of having an antibiotic-resistant infection. So it is really to people's benefit to investigate their allergies and talk to their doctor and do a little bit more digging. Okay, so now we know we talked a lot about, in that last little bit about what the problems were and what the challenges are with the current trends in prescribing. So now we're going to shift a little bit and talk about how to make a difference. And I'll just take a quick break and see if anyone has questions about the last bit we went through with the slides and statistics.
Hi, Kate, it's Wendy. That's really interesting information. I didn't realize that I had kind of made the assumption that antibiotic allergy kind of held with you the rest of your life, and didn't realize that there was such a high incidence of that being eliminated as they get older. That's interesting. I have a couple comments or questions, I guess. Catherine asked about the numbers of increasing of dental prescriptions. Is it due to increases in the due to dental infections? And this is kind of a related question. Dentistry is increasing in complexity for procedures. Does this have a role in the increase of antibiotic prescriptions?
It shouldn't. There are very few, it could. There are times definitely when antibiotics are needed, and there is a place for them for sure. But I think a lot of what we're seeing is antibiotic use when you look a little bit deeper at the data, it is times when it's not recommended. And we'll go through differences and when they are recommended and when they aren't. And there was a change in the recommendations. And so it could be that maybe some dentists feel more comfortable with the old regulations than with the new evidence-based practice. And when people do get kind of entrenched in what they're used to, it can be hard to make a change.
Right.
So there could be some of that. But it looks like the science is saying there's not a lot of evidence on giving prophylaxis before many procedures.
Right.
But we do see that still happening in practice.
Right. I think this is Dana asked the question, is there another way to say the penicillin allergy might no longer be an issue other than you could lose your penicillin allergy? I'm not sure if you covered that later in your slides about the being tested.
Yes, we can talk about, why don't I just answer that right now since
Okay.
it's on people's mind. I think if you try and approach it with the client, that you're really trying to help them find the best medicine for this infection or for a future infection that will really be the most effective for them and safest. So you're, their trusted care professional, and you're really trying to partner with them. So they can go see a doctor, and the doctor can give them a referral to an allergist, and then the allergist can do a skin test or an oral test. So that's the gold standard, is to get a skin test or an oral test. And I think the important thing with that is it could confirm that they do in fact have a penicillin allergy.
Right.
And then they know, that's great. Or it could be you actually don't have it anymore, and then they know. So I think whatever the outcome, it's a good piece of health information for people to know about themselves.
Right, one way or the other. Okay.
Okay.
Thanks.
So I'll keep going here. Sure.
Okay.
So with penicillin allergies, we did talk about just having that upstream lens, that prevention lens for people with allergies, and improving their next prescribing encounter. And for some people, it might take, 5 healthcare professionals that talk to them about this before they're really open to hearing about it. So the more healthcare professionals that can be on the same page, telling clients the same information, the more trusted they'll feel, and the more they'll be able to feel good about moving forward. So it is good for you to have information to give them. There is a patient handout available that our group worked with the BCDA to develop for you to be able to give to clients about penicillin allergies. So that's available either at our antibioticwise.ca website, and that's a great place to send the public for any questions about antibiotics in general or antibiotic resistance. So if you go to that website, in the campaign tab, there's a dental campaign, and you can see information there. And also it's on the yourdentalhealth.ca. You can get this and print it off and hand it out at your clinic. So another resource we have is a decision support tool that is for the prescribers in your practice. And this is a double-sided sheet to help when a patient says that they're allergic to antibiotics. This can help the dentist go through a flow chart to see if they can prescribe something else. So if there's a history of penicillin allergy, they can go through the flow sheet and say, oh, have they actually taken amoxicillin before successfully? And if they have, then penicillin is also safe to prescribe. So a lot of people say they're allergic to penicillin, but then actually they've taken another penicillin class drug and been fine. So this is for the dentist to go through and help to determine if they could prescribe something else. And if they can't, then it gives them other options for what other things to prescribe. So this can be great for you to pass on to the dentist in your practice too. And this tool is available on the dobugsneeddrugs.org website. And we also can mail it out to dentists. If you contact us and ask, we can mail some to your office to post up or use in practice. And then this is just the back side of the decision support tool, and it does have in the gray box here, it has some questions that you can ask the client. So do you have an allergy to penicillin? And if they say yes, you can give them a little bit of information about them, and then you can ask when the last time they had penicillin and what was the nature of their reaction. If they previously tolerated another antibiotic in the same class, and if they were ever hospitalized due to a penicillin reaction. If they were, then it is a contraindication to receiving penicillin for the rest of their life. So those are just questions that they can ask. And then I'll go over at the bottom of this tool, it does say 7 actions you can take to fight antibiotic resistance, and I will talk about that at the end of the talk as well. So the areas we have for improvement are just adherence to the CDA guidelines that allow for less prophylactic antibiotic use. Because there are very few conditions that remain that show that prophylaxis actually is indicated. So the rationale for the guideline revisions was due to the poor evidence on the effectiveness of it and a lack of an association between endocarditis and joint infections and dental care. The other reason why it changed was because of the risk of antibiotic-associated adverse events, such as the risk of a C. diff infection. So the general adverse effects outweighed any potential benefit, and that potential benefit was small. So the antibiotics before dental procedures are only recommended in patients with cardiac conditions at the highest risk of adverse outcomes from infective endocarditis that are undergoing invasive dental procedures. So another area for improvement was what we talked about, that the highest risk drugs are only used when the first line ones are truly indicated. And I put here the picture of the Bugs and Drugs app. So there's a website called bugsanddrugs.org, And this website is free to everyone in Alberta and BC because our program pays the licensing fee for anyone with those IP addresses in those two provinces. And you can go on this website. There is a dental tab, and you can type in different infections and conditions, and it says what is recommended as the first-line treatment and how long the duration of therapy is recommended to be, and it's evidence-based. And if someone is outside of these two provinces, they can purchase the app, but the website is free for everyone here. So another thing I just wanted to bring up is something you would maybe see in the future is individual prescribing portraits that may be provided to dentists at some point in the future. We are working with a program called the Therapeutics Initiative at BC, and we may look into providing dentists with each dentist in BC with a personalized profile of their antibiotic prescribing practices. So it would show them based on all the dentists in BC that we could compare them to, plus comparing them to our target provincial prescribing. So they could see in blue what their prescribing is, if they're prescribing more clindamycin versus amoxicillin or penicillin, and then what all their dentists, all their coworkers are prescribing, all the dentists in BC, and then the yellow would be the target provincial prescribing. So this would just help be an intervention to give dentists some feedback on best practice targets. So it would allow them to see how they differ from provincial trends and just provide that education on prescribing length and drug of choice. And it would be completely confidential as well. And all the information we get is anonymized. We don't have any information about people at all. And so our team developed 7 actions to fight antibiotic resistance in dental prescribing. And so they are listed here. The first was don't prescribe antibiotics for irreversible pulpits. Don't prescribe antibiotics for acute dental abscesses if there's no signs of systemic involvement. We talked about not giving antibiotics prior to dental procedures for patients with total joint replacement. And I won't read the rest to you because we've gone over them, but I did show you the BCCDC's penicillin algorithm, which you can use as a reference, and just knowing that penicillin rather than amoxicillin is the drug of first choice for most indications. So the actions for dental hygienists would be to provide education and teaching to clients with allergy labels, and then provide patient handouts to give a little bit more information. And this patient handout on antibiotics and dental care is at the Your Dental Health website. And you can also refer clients to antibioticwise.ca or social media channels, because we know that is where a lot of people are getting their information these days. And this is just some of the public outreach we've done through our group. We had our Say Nah campaign that was for colds and flus and dental procedures. And I did talk about that what we really want is communication that targets the general public and the clinicians. So that is how we will make change. And we are doing a good job overall. So in BC, this graph on the left shows from 1996 to 2016, the overall prescribing has been going down, which is fantastic. But where we see big change is the graph on the right. So in children, we've seen a 57% decrease in antibiotic use since 2005. And for the children 1 to 4, it's gone down 41%, which is fantastic. So some of that is due to new vaccines that have become publicly funded, because a strong vaccine program really goes hand in hand with antibiotic stewardship, because if people aren't getting sick, they don't need antibiotics. And then also with just education to the public. One other thing I just wanted to bring up is that there is no evidence that adding antibacterials to household products wards off infection. So it's important to look at what's in toothpaste and mouthwash that you're giving to clients, because if there's triclosan added, that can cause antibiotic resistance in the same way that medically necessary antibiotics can cause resistance. So it's good to make sure that there is no triclosan or quaternary ammonium compounds. So I put the Mr. Clean up there just because not everything that says antibacterial is bad. Bleach, alcohol, lye, those are all fine. But the addition of triclosan to things like toothpaste and mouthwash are not recommended. And I just listed my references for those who are interested, and I think the PowerPoint could be available to you to look at these if you want more information. And I'm happy to take any questions, so thank you so much.
Wow, Kate, that was really awesome. There's so much good information in there. I do have some questions through the chat function. Hannah asks, so her question is, so she said, Kate said 10 days is too long to prescribe for a course of antibiotics. So her question is, what should it be?
That's a great question. So if you go to www.bugsanddrugs.org, you can go to the dental tab and type in, any indication, and it will tell you what the recommended treatment length is. And even if you're curious, about something that the doctor is prescribing you for an ear infection, say, you can look on there and see if what they're prescribing is what's evidence-based. You always want to listen to your doctor, obviously, but it could start that conversation like, oh, you've prescribed 2 weeks, but it looks like 5 days, research shows that's enough. What do you think about 5 days?
Right. Yeah. I know there's been some information in news reports over the last several months and in the last year about do we really need to complete the full course of antibiotics? We were all kind of raised with the indoctrination of everybody has to finish their antibiotics no matter how you're feeling. And it really raised the question, is that, where is the evidence that says that?
Yes, that's a good point. Yes, and it will start to change, I think.
Yeah. I'm not sure if I'm going to pronounce the name right. Muzamil says, it's just more of a comment. He said, not everyone will lose an allergic reaction to penicillin. My father was 62, had penicillin only twice in his life, and at 62 he thought he thought he would be no longer allergic. However, he almost died from it. So I guess we want to stress that yes, there are true allergic reactions to penicillin that are life-threatening and have been life-threatening, but that doesn't mean that everybody follows that.
That's why it's good to have the patient talk to their doctor and go through a referral to an allergist and make sure that we're delabeling people appropriately.
Right. MJ made a comment, according to Kate, which are the health issues that need prophylactic antibiotics. I think you covered that in an earlier slide there with that list at the end. And then let's see, this is Tracy says, it's my understanding that prophylaxis is needed for those with joint replacement and are immunocompromised, elevated AC1 and HIV.
Yes, that would be, when people have comorbidities, it would take more of a careful look. I don't think I want to comment on exactly what that client would need without, knowing more about it. But if patients are severely immunocompromised, they would have more of a need for antibiotics in the general population. Right.
And I think that could be in consideration of the fact that they are more immunocompromised versus what we are talking about normally, the routine joint replacement, because that's one of those topics in the dental world that it really depends on. It feels like the way the wind is blowing as to whether the recommendation is to provide antibiotics prior to dental hygiene or surgical interventions.
Yes. Yes. And the point is never to deny antibiotics to those who need them. Right. We definitely want people to take them when it's needed. What we want to really look at is have a careful look and say, we know that 30 to 50%, or maybe even up to 80% of these people don't need antibiotics. Which people
Which
are those?
which ones are those, and not apply? Yeah, because you're right. We don't want to sprinkle it in our cornflakes just because
Right.
we know it helps some, right? Yeah. Dana says it would be great to see the application specifically for dental hygienists again. I'm not quite sure exactly what that means, but I'm thinking it means for dental hygienists to be able to prescribe for some medications in terms of those conditions that we can treat within our dental hygiene scope of practice.
And I think having this overall education is such a good backbone to your practice, because you do work so closely with the dentists who are prescribing. Hygienists are often recommending or even sometimes writing scripts that will get signed later. So
Right.
You really are the front line, and I think that's why it's important that you have this sort of deeper depth of knowledge about them.
Right. Tracy asks, I'm not quite sure what that means. It says, is subclinical doxycycline a problem with resistance? It is sometimes prescribed for initial therapy for periodontal disease, so for advanced gum disease.
So any antibiotic can develop resistance. It's just the way that bacteria can become stronger.
Sure. MJ's asking, just saying thanks. It was a great informative session and interested in the PowerPoint. I'll maybe get the, if Kate doesn't mind, I can certainly share the PowerPoint in PDF form with the people that had registered and attended tonight.
That's great.
Excellent. Yasmin asks about, what about chlorhexidine? It is a widely used antimicrobial rinse used in dentistry.
I don't know. I would have to check. I could get back to that person, but I don't know off the top of my head.
Okay.
And I did just see a comment come up asking about the Bugs and Drugs app, so I'm sorry if that wasn't clear. So the website is available free to everyone in BC and Alberta. So if you're in BC and Alberta, you can go to the website, www.bugsanddrugs.org, and see all the information. In the rest of the world, outside of BC and Alberta, that website would be blocked, and they would have to download the app. If anyone in the world wants the app, they have to pay. So it's the website that's free.
It's the website that's free, and the app is $15, $14.99 for everybody. Gotcha.
That's right.
Perfect. Okay. Well, good to know. Well, I'm not seeing any more questions. I just have a couple. We did mention the farm animals because I had a few questions here. I think you've covered that. Here's a question. I'm up north and there are no allergists here. What should I do?
And that is tricky. I do hear this a lot from rural places in BC that, that's great. I want to get a skin test. Where in the world can I do that? So unfortunately, it is, you do have to travel to see an allergist, which often requires going to a big center, which is sometimes Vancouver. So hopefully in the future, we will be able to have, more mobile ways, or maybe nurse administered or pharmacist administered allergy tests, but at this point it does require travel to a specialist. But it really is in the patient's best interest, which can be hard when it's not an acute infection that they need to travel and take care of this now. But because of the risk of second line medications having more health risks, it is really up to that patient to make it a priority, and definitely to their benefit to make it a priority to do so.
Right. Well, thanks for that. There was an earlier question about, I think somebody had asked, is there any chairside tests that are available? So apparently not, but that would be a great initiative, wouldn't it, if there was some way to apply that in a simpler fashion, I guess, for patients.
Yeah, and some of the hospitals do it, like at St. Paul's they do it. So at some different hospitals, if you're admitted, they will do it. But as far as an outpatient procedure, it's more difficult without going to see an allergist.
Allergist, okay. Well, I'm not getting any more questions through the chat function, and we're approaching 8 o'clock. I just want to thank Kate so much. I'm going to take back the presentation here. I'm just going to put up the slide if I can find it. There we go. Okay, just give me a sec here. There we go. There's the survey. It's a Survey Monkey. It's right there. I will send the link out as soon as I click off here via email. So if you're the eager beaver and you like to get things done right away, please fill out our survey. We do like to hear from our members as to what you liked and what you didn't like and what you'd like to hear in the future. I was happy to hear that you mentioned vaccine hesitancy. So for those listeners that are still on the line, we do have a webinar addressing vaccine hesitancy by a pharmacist November 28th, and you can find that information and register for that course. You can just email me directly, or the information's on our website under professional development. And on that note, I'm going to close off and say thank you, Kate. We really, really appreciate you spending an hour with us and preparing this presentation and helping us gain some further understanding about what it is to be an antibiotic steward.
Thank you so much for having me. I really appreciate being here.
Okay, thanks very much and good night, everybody.
Okay, take care.